Hey, Crispy Brown here, Med Preservation Inc., coming to you from the Hampton Inn. Got these lovely curtains behind me. Been at this hotel for a couple months now. Same room, just like Groundhog Day. Same room every week. And you wake up and you do it again. And you wake up and you do it again. Anyway, tonight I want to talk to you about Expunge, and specifically the RXM Expunge. Now, I know this has kind of been around for a while, and some sites have done it, some haven't. Reasons to do an RXM Expunge, and let me just explain what that is. It's basically where you wipe the drug dictionary in RXM. This drug dictionary controls med-rec strings and also e-prescription strings. So, reasons to do that. One would, first and foremost, is really the PE 257, which is a Meditech Priority Event 257, where Meditech realized several years back now, it's probably been 5 or 6 years since this originally came out, that they had some programming issues and weren't picking up on recycled NDCs. And because of that, there could be some internal mapping issues. And so they put together a priority event around this. It's pretty lengthy. It takes a lot of time to do this stuff. There's several huge reports you have to go through where you basically can compare the internal drug reference to the shell of the drug, or what you actually think that you're sending to the pharmacy. And so I think I've done 3 of these now. Like I said, pretty time consuming. So that's the first reason to do one. The second reason is if you're having missing strings, or like a lot of duplicate drugs. I see that a lot. It's unorganized. It's hard to keep clean. Like, no matter what you do, every time you do a load, it's just, you're like, man, I swear I did that. I swear that drug was there, and then it just kind of disappears, which that happens some anyway. You really have to manage the drug dictionary in RXM. So those are all reasons to do an expunge. So if your providers are complaining about the strings not being there, and you plan on being on the EHR for a while, you don't have any plans to upgrade anytime soon, then you might want to think about doing an expunge. And definitely for safety reasons, if you haven't done PE 257, then you probably need to make sure you do that. So I know a few sites that have actually done this twice. They did it early on in the process, and Meditech didn't really have all the steps together, didn't have the programming together, or maybe the drug dictionary wasn't managed well, So some sites have had to do it twice. So and there is a little bit of downtime if you're using RXM. Usually I can get this done over a weekend, so the providers aren't off the system for too long. And usually it's not even that long if you're talking about real downtime, but that's what it takes to fully build back out RXM. So first thing that happens is Meditech will expunge all your drugs, and so these drugs just kind of go away one by one, and you see them disappearing, and all of a sudden they're just gone from the strings, and where you would normally order from in RXM or in the EHR. So then once Meditech gets done with that, the next thing that needs to happen is you have to do an FSV load. And so first you start out with that allergy FSV load just like normal. Then you do the pharmacy FSV load, and then you do the RXM FSV load. And so once you get the RXM load back in there, that's when your drugs come back. But now they don't have any strings or anything that kind of goes along with them. So the next step after you do the RXM drug load would be to go back in and add your strings in. You can either script them in, like a lot of times I'll download a report, a file, build a report, download a file, and just map those strings to the new mnemonics and can script them back in that way. Or the First Data Bank, no, excuse me, Dr. First Smart Strings is a really nice product, and I like those a lot. Seen them used a couple times, and they're real easy to load in, and they're clinically accurate. So if you haven't looked at that product and you're looking for a good set of strings, I would recommend those. I'm no affiliation with Dr. First, but I just really like that product. So once you get the strings back in, then the next thing that happens is you want to make sure those are complete strings, and I highly recommend complete strings. There are some First Data Bank strings that kind of come with a product with the FSV loads, but they're just partial strings, and quite honestly, there's some dangerous doses in there. So I usually recommend to turn those things off. I don't want them in there. I would rather script my own clean strings in, or use this Dr. First Smart product. So and so when I say complete strings, I mean what the dose, the route, the sig, the day supply, the quantity, units, dispensing units. Got to have dispensing units in RXM. It's very important. A lot of times those don't come in on the drug, so you have to make sure you go get them in there one way or another. There's a routine you can run, or sometimes just mainly building those, and then refills as well. And so this really allows the provider just kind of click and go, and doesn't have to fill out too much when he or she is sending a prescription. So highly recommend complete strings. I also recommend the common list. Now, people used to use asterisks, way back in the day. This is kind of an old build method before the common field was there, but common field will allow you to just shorten the list that the providers are looking up into, and instead of the whole 30,000 item RXM drug dictionary. So it's a pretty big dictionary, and there's stuff in there that you would never prescribe, but it's out there on the retail market one way or another. It might be compounding supply or something like that. But so the recommendation is not to turn any of that stuff off, but use the common list and just keep people in that common list. And so if a provider can't find something, and this goes anytime, not just after expunge, but you would want to move that drug to the common list and build it out so it is easier for the provider to use. So the next thing I usually do is if there's any kind of procedures, like if they're an ambulatory clinic, they're using MPM, I will generally go back in and replace those drugs in the procedures. So those office procedures, like office injections, like a Rosefid injection or something like that, will still be able to be used and will work properly. So we build the procedures back. If there's any ambulatory sets that are being used that had drugs in them, you would want to go back in and replace those as well. A lot of times I will build out auto stops for sites, which just makes usually just on antibiotics that, 7 or 10 days, whatever the site wants, and those will automatically DC from the profile, and so that, the next time the patient presents on MedRec, that medication will no longer appear on the profile, and just makes it a little bit easier for staff, and they don't think it's an active prescription or that the patient's still taking it. So then the continue from ambulatory link is another piece. And this is basically when you're doing MedRec, patient comes into the hospital, nurse or doctor, pharmacist, whoever it is that does the MedRec will, usually it's a nurse, and then the doctor comes behind them and does what they call the continue from ambulatory process. So with that, there's a link in the background. So if you only carry like lisinopril 10, but the patient may be taking 20 or 40 at home, you can do what they call continue from ambulatory link. And so when it crosses over to pharmacy, the doctor continues that, and it crosses over to pharmacy, it will map to the right drug or to the right product that you have. So if they're taking lisinopril 20, or the patient's on lisinopril 20 at home, it will come over as lisinopril 10, 2 tablets, and then on the way back out, it will cross back over to the lisinopril 20. So pretty slick functionality, but you have to build it out. And then really, I guess the last thing I do when I go in for an expunge is I try to put the brand names back in, because the way Meditech's set up is if the brand name products is no longer made, those names just kind of vanish, or those products, both names and products, really vanish from that drug dictionary. And so then a provider won't be able to look up that prescription or that MedRec string from while they're trying to do their job or whatever, order their prescription. So what I do is I try to go back and put a list of these brand names back in, and it's anywhere from 100 to 150 depending on the site and kind of what they're used to. But more often than not, I would say the providers try to order from a brand name, so this is a pretty important piece. Like I said, it's a time-consuming process, but definitely can help straighten out your EHR and your e-prescriptions, and and your MedRec, and usually is a physician satisfier if it's done right. So if you have physicians complaining about that, it's something to think about. But, I think that's about all I wanted to cover tonight. So with that, I will sign off, and I just want to tell you to always remember to be kind, be careful, and choose joy. Thanks. We'll see you next time.